Now, I'm joined by Dr. Paul Thompson, Director of Cardiology at the Hartford Hospital and Professor of Medicine at the University of Connecticut School of Medicine in Hartford, Connecticut, to discuss detecting coronary artery disease in older athletes and what to recommend when you find it. So, Paul, welcome to ACCEL. Why don't you frame this issue a little bit with us in terms of the older athlete and coronary disease, which is prevalent in this population, and how do you deal with these folks?
Well, it's not easy to deal with them, Dr. Bove, and thank you for having me on ACCEL. So there are a couple principles I think we work from. One principle is that most cardiac complications in adults are due to coronary artery disease, and that's both acute MIs and sudden cardiac death. And I think all the studies show that exercise actually increases that risk. Now, the cause of most of that is usually plaque rupture with an acute coronary thrombosis leading to the event. And the problem beyond that is that most of these lesions are undetectable because they're not highly stenotic before the acute cardiovascular event. So that makes detecting it fairly hard to do. Routine exercise stress tests don't look that promising, although I'd like to come back to that theme. And so what one is really left dealing with is when patients develop symptoms. Now, what do you do if coronary artery disease gets detected, either by some imaging test or from some symptoms? What I'd say you have to do is you have to treat the dickens out of the risk factors. Because if one thinks that plaque rupture is the cause of the events, we think that plaque rupture is related to how much cholesterol there is in the atherosclerotic plaque. So you need to do things that get cholesterol out of those atherosclerotic plaques. I've been very impressed by a study that looked at carotid thickness using carotid MR studies. And what they showed is that when they treated a bunch of people, just regular people, I think there were 89 in the study, when they treated them aggressively with statins and niacin for 3 years, they got very little regression in the first year, but they got a lot of regression during the second year. So what I try to do with my athletes who want to go on and run competitively or something, I certainly talk to them about the risks, but I really talk to them about the fact that I'd like them to give me 2 years of very intense lipid risk factor reduction with the idea that we're probably stabilizing that plaque and reducing their risk if they must continue to exercise.
So the 50-year-old man that comes to you or me and says, I've got a little time in my life, I want to start doing some running. You do a stress test and it's normal, and you look at his risk factors and they're pretty bad. I think what I'm hearing you say is that coronary atherosclerosis isn't an inevitable process that progresses all the time, that if you intervene with aggressive therapy, you can at least stabilize a plaque. I know there is some older quantitative data that says you can even reverse the plaque thickness in a coronary artery as well. So do you have to inform these individuals? I think I'm hearing you say that you're not going to say don't ever go out and do any exercise or anything, but here are the conditions that you need to meet to make sure you're going to be doing this safely.
That's right. And so for that person who's asymptomatic, had a normal stress test, my advice for them would be to start your exercise program, progress slowly, pay attention to yourself, because when we go back and look at those individuals that we've interviewed about sudden death during exercise, many of them did have symptoms that they passed off as something else. A lot of them don't, but about half of them have symptoms that they pass off. I may be more aggressive with aspirin therapy in that group. For example, somebody's going to go running a marathon. You could at least make an argument, especially someone who's 50 years old, that, aspirin, 81 milligrams would be a useful approach. But clearly, getting the risk factors under control with statin therapy or whatever you need to do is a great idea.
But in your mind, and I think I've heard you say this, is that if you get aggressive lowering of LDL, your expectation is you can stabilize that plaque.
I think that's the expectation, and I think the studies show that. First of all the studies that have used statins have shown a reduction in acute cardiac events. Also, there were plenty of studies that showed that aggressive lipid reduction with IVUS studies and whatever can actually reduce the amount of plaque in a coronary artery. So, I'm very enthusiastic about treating these people who have risk factors. And I'm very enthusiastic about treating those people who have known coronary disease that want to do something competitively and athletically. Now, it's very easy to say, look, you can't do it. But, for a lot of these people, especially people who've been athletes all their lives, it's part of their image of themselves. And, what I always say is being dysphoric or being slightly depressed doesn't work very well. A lot of people that get addicted to exercise actually are people that are not manic depressive, but they have little down periods. And they feel that those down periods can be eliminated by them being physically active. They feel better about themselves They feel better about their day. They feel better about their lives by some exercise. They're actually exercise addicted. Well, it's a little hard on my part to change their lives a whole lot by saying you can't compete, you can't exercise, you can't train hard because you got coronary disease. What I want them to do is do it safely, so let me treat you aggressively for 2 years and then we'll let you do your stuff.
So you do a stress test and it's positive and you documented coronary disease, patient's doing good therapy. How do you give them a guideline for intensity?
What I basically tell people is the talk test. I don't like to get people doing a lot of heart rate monitoring, to tell you the truth. And one of the reasons I don't like to do that is they find other things. They find extra beats. They find, things bother them. So what I like them to do is I like them to exercise to the point where they're slightly breathless. I think it was called the talk test or something. One would exercise to where you had a little trouble carrying on a conversation. And that's obviously the point where you're producing more CO2. The ratio of CO2 production to oxygen consumption is over 1, so you have to breathe a little harder to blow off that CO2. And so that's a good point to tell people exercise to that point and kind of maintain it. Not too breathless, but not unbreathless.
Pretty easy measure when you're out walking or jogging. It's a good self-assessment tool.
The maximal heart rate stuff, if you don't measure it on the treadmill, it has a large standard deviation. A lot of people don't know that. They always remember 220 minus your age, but it's not just 220 minus your age. The standard deviation is 19 beats, which means the 95% confidence limits is almost 40 beats one way or the other. So I really like them to use the talk test to exercise to the point where they're slightly dyspneic. If
I was going to ask you to give me a quantitative guess on that, where do you think it would be? About 50% of VO2 max?
It depends on your fitness level. If you're quite fit, you can raise your anaerobic threshold or your ventilatory threshold to 70. And Frank Shorter, the winner of the 1972 Olympic Marathon in second, 76 in Montreal, he had a ventilatory threshold of 92% of his maximum. That's because he's very fit. A person starting out, it's about 50%. Getting in good shape could be 70%.
Okay, so then the other thing is if somebody comes to you, and this happens now, 55-year-old, hasn't done a lot of exercise, says, I want to run a marathon, which is the new thing to do now. What kind of program do you give them? 2 years at least. What do you do?
I don't routinely exercise stress test all those folks. Now, I've got to tell you that I think the new guidelines, when they come up, because I'm part of those guidelines, are going to recommend stress tests for those group, but I don't do it all the time. So what I tell them to do is to start out slowly, progress slowly. If it's somebody that's never done it, I'll go so far as to try to get them in touch with one of the local coaches who can kind of help them along. But clearly, progress slowly. Pay attention to your symptoms. Make sure they know that it's not called heartburn for nothing. It can often be a sign of inferior wall ischemia. And just to have them progress slowly, treating their risk factors if they have them simultaneously.
Yeah. Stepwise participation, 5K, 10K, half marathon, and what do you do with that?
Yeah, so I have them primarily walk 5Ks. And then have them run 2 telephone poles and walk 1 telephone pole or something like that. Have them progress slowly. Oftentimes, it's good if they can get into a group of people that are doing it at the same time. But clearly, very slow progression.
Mm-hmm. I don't usually tell people that the first thing they ever get into with competition is a marathon. They ought to be getting in some other crowds and doing some other things and getting used to that a little bit.
Absolutely, because you don't want to have just get into shape. You need to get into race shape. And you kind of got to work up to the whole sense of that stuff.
Right. Good news for people that do want to exercise, and I think your point of view is one that I agree with, is don't tell people they can't. Give them the parameters that allow them to get back to doing what they like to do with the limitations that they need to understand. Important material. Again, every time you come to ACCEL, you give us a lot of very good information, so I want to thank you again for being here.
Well, thank you, Dr. Bove. It's always a pleasure to be with you here.